Hello, good morning, good afternoon, good evening, wherever you are. Very welcome to the WHO RSV Roadshow webinar series. Today I will be your host. My name is Lewis Bond. I'm a pediatric infectious disease specialist at the University Medical Center Utrecht and the chairman of the RSVNet Foundation. And on behalf of the World Health Organization and PATH, I'm very happy to be here at our 6th webinar series. I hope you find it as exciting as we do that we have developed a communication toolkit for the development of RSV vaccines for low and middle income countries. We have developed 7 monthly educational web events that hopefully soon end in March. Our target audience are policymakers and decision makers, and I think you all understand that we target a broad audience here in low and middle income countries. At the end of the day, our goal is to increase RSV awareness of RSV infection and to promote RSV prevention in every little corner of the world. We have developed modular PowerPoint slide presentations with speakers notes that are available to all of you that you can download from the RSVNet site. At the right side of this slide, you can see the different topics that we've had. And today, February 13, we will discuss RSV surveillance in infants and young children. So who is going to present today? I will tell you in a second. I wanted to remind you that we like to receive your questions so that we can discuss them later on during the meeting. Please use the Q&A button. Please do not use the chat function. So the Q&A button, please. So Niranjan is our first speaker. He's a senior medical officer at the teams of PATH, and he is an expert in vaccine development for low and middle income countries. And in the first 30 minutes or so, he will give you a broad view on the relevance of surveillance. Then afterwards, we have asked Dr. Imran Nihatu, who is an associate professor in Karachi, Pakistan, with a broad expertise in pediatrics, infectious diseases, and global health, who has published in many major journals to give us his reflection on what we are going to hear from Niranjan. Niranjan, please take it away.
Thank you, Lewis. I really appreciate it. As Lewis just mentioned, so my name is Niranjan Bhatt, and it's really my honor to be able to talk to you about respiratory syncytial virus surveillance, or RSV surveillance, in infants and young children. As you saw in a previous slide, there will be a talk on RSV in elderly, but this session will focus specifically on infants and young children. Here we'll cover systems that can provide information on the burden of disease in a given context, identify high-risk groups, or support RSV product development as products become available. So in terms of our agenda, today we'll discuss the basic considerations around RSV surveillance. We'll talk first about key surveillance concepts as they pertain to RSV and informing public health action. Then we'll focus on sentinel surveillance as a key option for LMICs, for low and middle income countries, to track RSV and other disease activity. And then we'll consider additional surveillance options if more information is desired and extra resources are available. So let's start out with just talking a little bit about what is respiratory syncytial virus, or RSV. I believe there was a session earlier talking about the clinical aspects of RSV, but here we can just give a short summary. So RSV is a virus that's really easily spread throughout the community. Virtually everyone gets RSV at some point in their lives, usually by 2 years of age. And the disease is often mild, like a cold or upper respiratory infection, but can be severe or deadly even for infants. Transmission can occur through sneezing, coughing, and transference from contaminated surfaces. Repeat infections can occur over the lifespan since infections induce only partial immunity. And although any child can get severely ill or hospitalized due to RSV, there are children at highest risk, and these include those that are under 6 months of age or have comorbidities like heart and lung disease and prematurity, or that live in a socioeconomically disadvantaged area. So having discussed RSV in general, let's now turn our attention to disease surveillance, some general concepts as well as specifics about RSV. So disease surveillance is, what is disease surveillance? It's an ongoing process involving the systematic collection, analysis, interpretation, and then dissemination of information regarding the occurrence of disease in defined populations. There are different kinds of surveillance that can help enhance understanding disease activity, and this can act at the global, regional, or national levels. And this information is important for public health action. So then why track activity for RSV? As we talked about, RSV is incredibly common respiratory virus, and this results in a very large disease burden worldwide. And so it really urgently needs to be addressed. Surveillance for RSV is critical for informing strategies to reduce disease, particularly among at-risk populations, and this focusing on younger children as well as older adults, as we'll talk about in a later session. With such a large disease burden, understanding RSV's disease activity really is essential for informing prevention programs. And that includes the new RSV maternal vaccines and long-acting monoclonal antibodies that have been launched in the past couple of years. So what is this large global disease burden that I've been talking about? Well, in 2022, global annual RSV burden estimates were updated and published in The Lancet, and those are provided on the left-hand side of the screen. Those estimates found that in 2019, RSV was responsible for a staggering 33 million episodes of acute lower respiratory tract infection, approximately 3.5 million hospitalizations, and over 100,000 RSV deaths among children less than 5 years of age worldwide. Overall, RSV accounts for 2% of the global mortality burden in children under 5 years of age and 3.6% among children under 6 months of age. RSV in children under 6 months of age accounts for 20% of acute lower respiratory infection episodes and almost half of all RSV deaths in children under 5 years of age. And young children are at particularly high risk of severe RSV infection because they lack pre-existing immunity. And then what you can see on the right side is that the difference between RSV mortality in high and low income contexts is substantial. So as product availability broadens, expanded surveillance is needed in low and middle income countries where RSV's disease burden is disproportionately high. Estimating the burden of RSV can help countries justify introducing interventions and to monitor impact once they are initiated. Understanding the epidemiology of RSV can help inform when, where, how, and for whom vaccines can be introduced. In other words, through understanding of the seasonality within the country and understanding the populations at highest risk. Ongoing surveillance can monitor impact, as well as understand the burden that's been averted following the introduction of these interventions. So tracking the activity of multiple respiratory pathogens is possible by integrating across pathogen surveillance, including surveillance for influenza, COVID-19, as well as RSV. So before getting into the specifics of how RSV surveillance currently works and considerations for the future, it's good to first understand some general considerations that form the basis for any surveillance effort, including for RSV. There are different surveillance designs available that can be used alone or together, and they provide complementary information. And each design has different aims as well as different resource requirements, which we will describe over the next few slides. So a national mosaic surveillance system, including for RSV, would be informed by clear national priorities and disease control objectives. And a good resource to learn more about this is the document that's referenced here, WHO's Crafting the Mosaic. So in general, surveillance approaches can achieve a variety of aims depending on the design. And we'll talk more about different designs that can help achieve these aims. Some are more likely to be feasible options for low and middle income countries than others, given the differing resource intensiveness of the different systems. So for most countries, monitoring seasonality, identifying at-risk groups, and characterizing burden of disease will be the priorities of RSV surveillance. So the WHO outlines different surveillance approaches in the document that's referenced at the bottom, a framework for resilient surveillance for respiratory viruses of epidemic and pandemic potential. And this document categorizes surveillance into 3 domains. So the aims listed in blue under domain 2 are high priority for RSV surveillance. Therefore, the appropriate surveillance approaches should be utilized to achieve these aims. Overall, when determining a national surveillance strategy for RSV, countries will need to clarify their aims and identify the surveillance type that's best suited to achieve those aims based on available resources. So this slide shows some of the different surveillance approaches that are and could be leveraged for RSV. The RSV objectives listed in domain 2 on the previous slide are the priority objectives. And for most countries, as we said before, monitoring seasonality, identifying risk groups, and characterizing burden disease are those priorities. So sentinel surveillance is a core approach for meeting domain 2 surveillance objectives and is the primary approach for monitoring respiratory diseases globally, most notably for influenza and SARS-CoV-2. As a result, sentinel surveillance is a primary but not the only approach for monitoring RSV globally. Sentinel surveillance can achieve a variety of aims depending on national priorities, including the monitoring of seasonality and severity in at-risk groups or target groups, tracking disease spread, and providing data to support disease burden estimation in hospitals, which can be extrapolated to regional or national levels. So let's focus a bit more on sentinel surveillance. So sentinel surveillance is widely used for respiratory disease detection, and it's the systematic collection of data on a routine basis for a select number of sentinel sites by applying a standard case definition. And this slide provides an overview of some of the key components of sentinel surveillance, which we'll dive into in the next few slides. Sentinel surveillance can't provide the entire RSV picture in a country because it's not tracking every single case. But if conducted well, it is a surveillance method with strong data quality and value for money that can leverage existing resources across pathogens. Strengths include the ability to inform disease seasonality patterns, but can also provide information on disease trends, spread, and severity, and inform situational awareness. It can also provide data to evaluate the impact of disease control programs and act as a platform to support other surveillance and research efforts. If a country is seeking countrywide burden of disease, mortality, vaccine impact, cost effectiveness, virologic diversity, etc., then additional surveillance or studies would be needed. So the goal of sentinel surveillance for RSV is to gather timely and high-quality epidemiological data and specimens to meet some of the objectives highlighted earlier. Sentinel surveillance prioritizes quality over quantity, using well-trained and supervised staff to collect quality data and specimens from a subset of health facilities that are representative of the larger population rather than collecting data from all health facilities. Given the burden of RSV in young children, health facilities that serve pediatric populations should be selected for sentinel surveillance. The data is collected from a representative sample of cases enrolled from those select sites. Again, not all cases. And if available, existing sentinel surveillance systems, such as those for influenza, can be leveraged with adjustments for RSV. So a commonly used case definition for capturing severe respiratory disease, such as influenza or COVID-19, is the WHO SARI, or Severe Acute Respiratory Infection definition, which is described as an acute respiratory infection with a history of fever or measured fever of 38 degrees centigrade or above, and cough, with onset within the last 10 days and requires hospitalization. This case definition has been widely used for influenza surveillance, but it does have some limitations for RSV surveillance. Notably, a significant proportion, more than 50% of RSV-infected young children and elderly patients present without fever, and RSV infection often presents with signs of apnea or sepsis in infants less than 6 months of age. Given that burden of severe RSV disease is high in children less than 2 years of age, and particularly so in infants during their first 3 months of life, surveillance does need to be focused among children less than 2 years of age. And this is an age group that has not often been well covered by influenza surveillance using SARI. So to address this, an extended definition has been proposed for RSV surveillance that is broader than the current SARI definition to efficiently capture severe RSV cases among those at the highest risk. And this extended case definition is currently in use by 25 countries participating in the WHO GISRS RSV surveillance pilots, which we'll talk about in a moment, which aims to establish a global system of integrated surveillance and response to influenza and other priority respiratory viruses with epidemic or pandemic potential. So let's turn over to the question of RSV specimens. How are they collected, tested, and reported? So after a patient is screened and has been determined to meet the clinical case definition, a respiratory specimen is taken as outlined by a sampling strategy, which is a predetermined process for selection of the patients and specimens to minimize selection bias. The specimen is collected via a nasal swab. And an optimal type of clinical specimens for the detection of RSV really depends on the age of the patient. So for infants and young children, a nasal swab taken from the mid-turbinate of each nostril has been found to be high yield for recovery of respiratory viruses. In particularly young children, young infants, nasopharyngeal aspirates can also be used. The specimen is then sent to the laboratory for testing using an RRT-PCR assay, which means real-time reverse transcription polymerase chain reaction. And RT-PCR is the gold standard in RSV detection, and it's become widely available following COVID-19 pandemic. And it's because this kind of test can test for multiple respiratory pathogens at the same time. It has a high sensitivity and specificity. The turnaround is quite rapid. Usually, and it is adaptable to changing needs. It's recommended to test all pediatric cases that meet the case definition, not just those that are influenza or SARS-CoV-2 negative. And testing algorithms should be adapted based on country needs and resources. You may opt to use either an RSV-specific test or a multiplex that includes other respiratory viruses, such as influenza or SARS-CoV-2. And in some settings, typing of RSV, meaning RSV-A versus RSV-B, is recommended. In addition, genomic sequencing of RSV can be done. While RSV does not evolve as quickly as respiratory viruses, it's recommended to sequence a number per year, some number per year, just to monitor evolution. So then once you have the data, how and where should the RSV data be reported? This is reported routinely, and so case-based clinical, epidemiological, and laboratory data would be reported to the national as well as global surveillance platforms. And regular reporting of data enables monitoring of seasonality, and that will then inform your immunization strategy. Any genomic sequencing data that's available should be uploaded to global surveillance platforms at least twice a year. So RSV surveillance can leverage existing respiratory disease sentinel surveillance systems, as we mentioned before. Sentinel surveillance is the most likely system to already be in place and or to be set up in low and middle income countries, making it a core option when considering RSV surveillance approaches. The WHO's Global Influenza Surveillance and Response System, or GISRS, is one such system. It was first established for influenza, and then it was expanded to include SARS-CoV-2 as well as RSV. And the WHO conducted a pilot study that added the RSV surveillance to a subset of the GISRS sites, including some in low and middle income countries. And they were able to show that monitoring of RSV can be achieved without adversely impacting the sentinel surveillance system for the other pathogens. RSV also has the potential to be built into other existing pediatric sentinel surveillance systems for other vaccine preventable diseases, such as rotavirus. All right, so let's just look at some key takeaways around sentinel surveillance. The global guidance is to integrate RSV into existing surveillance for other pathogens. Many countries already have sentinel surveillance in place for other diseases. Integrating RSV into the sentinel surveillance requires adding, leveraging, and optimizing resources within existing systems. Optimizations should allow for prioritizing severe pediatric populations, severe disease in pediatric populations. In a broader, meaning a more sensitive case definition, may be considered to inform vaccine introduction. For RSV detection, RT-PCR is considered the gold standard. Investments during the COVID-19 pandemic triggered progress in low and middle income countries that use RT-PCR, allowing for more accurate detection than was previously feasible. Sentinel surveillance does not, however, provide the complete picture of RSV in a country. And so in the next few slides, we'll talk about other kinds of surveillance and studies that can fill gaps in the data package, but require additional resources. Countries then can decide which of these options are priorities and which are feasible within their specific contexts. So there are several surveillance and epidemiological aims that are critical for characterizing RSV and vaccine introduction, but are not addressed through routine sentinel surveillance. So this slide lists some additional surveillance options that may be considered for better understanding of RSV. Syndromic surveillance is where you report total cases with the defined clinical features or syndromes. Electronic medical records surveillance, or ICD-10 surveillance, use existing administrative or electronic health records as data sources for disease surveillance. And then there's mortality surveillance, where you intentionally collect data on deaths as part of other surveillance platforms. Some of these surveillance approaches can be built on top of existing sentinel surveillance platforms. And these designs are not required in all countries. They are more resource intensive and may not be feasible or prioritized, especially in low and middle income countries. Several surveillance and epidemiological aims are critical for characterizing RSV and vaccine introduction, but are not addressed through routine surveillance. Longitudinal studies, also known as cohort studies, allow for ongoing follow-up of populations of special interest that may be underrepresented in other surveillance designs. For RSV, target populations of particular interest include young children, particularly premature babies and newborns, and then burden of disease studies. For routine surveillance, more specific case definitions are applied, enabling more efficient resource use by capturing a representative sample rather than all cases. In contrast, burden disease studies involve modeling or it requires exhaustively or more sensitively capturing cases. And so calculating burden, it typically involves modeling and specialized expertise of the surveillance data. For example, using data on a number of hospitalized RSV cases to estimate then the total number of RSV cases, including those who have mild symptoms or those not seeking care. Characterizing RSV burden and the number of potential cases averted with preventive strategies can be very compelling to policymakers as part of their vaccine introduction strategies. So then health economics modeling helps inform the baseline of RSV disease's impacts on public health, what the immunization program will cost, and the effects of the intervention on public health. And then finally, the cost effectiveness of the intervention. And then finally, knowledge, attitudes, and perception studies help assess health-related beliefs as well as behaviors in the context of RSV prevention. So in summary, RSV really is the leading cause of hospitalization and severe respiratory infection in infants and young children, which underscores the importance of surveillance to inform public health actions. More surveillance data are needed for RSV, especially in low and middle income countries. Some systems are already in place in tracking RSV disease, mostly in higher income countries. Many of the surveillance systems in place can be leveraged to improve RSV disease monitoring, but require special attention and investment. Sentinel surveillance is the primary system used where RSV cases are detected worldwide. This type of surveillance offers balance between cost and usefulness and completeness of the data. Data from other surveillance systems can complement Sentinel surveillance, and they provide a more complete picture of RSV spread, burden of disease, and the impact of new RSV products. Surveillance systems already in place can be leveraged to integrate RSV disease monitoring, but require special attention and investment. Countries should consider what modifications to the case definitions, target groups, and testing algorithms that may be needed given their own particular national aims. So at this point, I will turn it over to Dr. Imran to give some personal reflections on RSV surveillance. Thank you.
Thank you, Niranjan, and thank you for the opportunity to reflect on today's insightful presentation on RSV surveillance in infants and children by Dr. Niranjan, who has provided a comprehensive overview. I want to take a few moments to build upon his discussion, particularly in the context of low and middle income countries like Pakistan. RSV is a leading cause of hospitalization and severe respiratory illness in infants and young children worldwide, with 33 million episodes, 3.6 million hospitalization, and more than 100,000 deaths. The burden is undeniable. However, what is particularly concerning is that 98% of RSV-related deaths occur in LMICs, where surveillance infrastructure is often limited. In countries like Pakistan, where acute respiratory infections remain a top cause of child mortality, RSV surveillance is not just a research priority, it is a public health imperative. Understanding seasonality, burden, and high-risk groups is crucial for designing effective prevention and immunization strategies. RSV is often underdiagnosed because it is clinically similar to other respiratory infections like influenza and bacterial pneumonia. Testing is not routinely available in all healthcare settings. There is limited national level epidemiological data on RSV, making it difficult to estimate true incidence, mortality, and economic burden. Current pediatric RSV hospital admissions in many of the LMICs are likely underestimates as only severe cases are captured. Resource constraints in government hospitals and rural areas mean that RSV detection and management are often not prioritized. And access to advanced diagnostic tools such as RT-PCR for RSV detection remains limited outside major urban centers. While many countries like Pakistan have influenza and COVID-19 surveillance systems, RSV has not yet been fully integrated into the routine sentinel surveillance program. If I talk about something, some data from Pakistan, we do have some good data coming out from Pakistan over the years. For example, in children under 5, meeting the definition of ILI or SARI, collected from 8 influenza sentinel sites in Pakistan for 3 years, 28% were positive for RSV in the high season, that is from October to April. A 3-year prospective study at one of the tertiary care hospitals found that 19% of the pediatric ARI hospitalizations were RSV positive. In another rural cohort in Sindh, a southern province in Pakistan, the incidence of RSV-associated severe pneumonia was found to be 4.3 per 100 child years in the first 6 months of life. And in a mortality surveillance in Karachi, RSV positivity was 2.1% in the deaths which occurred in the community and 5.6% in deaths which occurred at hospital. In other etiological studies, the ANISA study reported that RSV was the leading viral cause of neonatal infections, with an incidence of 5.4 cases per 1,000 live births in Pakistan. So to address these, gaps in knowledge, gaps in disease burden estimation, and we need a multi-pronged approach. We should leverage existing influenza and COVID-19 sentinel sites to include RSV testing using WHO's MOSAIC framework for respiratory virus surveillance, increased access to RT-PCR and multiplex testing for RSV in major hospitals and research institutions, and strengthening clinical case definitions to ensure that RSV is captured even in febrile infants under 6 months who may not present with typical symptoms like cough. We should conduct burden of disease studies to quantify RSV's impact and its economic cost, invest in longitudinal birth cohort studies to understand age-specific vulnerabilities. With the RSV prevention tools now available, maternal vaccines and long-acting monoclonal antibodies, surveillance will play a key role in guiding national immunization strategies. Given high neonatal and infant mortality rates in countries like Pakistan, RSV prevention should be integrated into maternal and child health programs, and policymakers should consider RSV in the national health policy agenda alongside pneumonia and influenza prevention efforts. With the global expansion of RSV prevention strategy, countries should prioritize RSV in their public health agenda. A strong surveillance system will allow us to move from reaction to prevention, ensuring that every child, regardless of where they're born, has access to life-saving interventions. Thank you.
Thank you, both of you. That was really wonderful. And on behalf of, I'm sure, all the viewers, I would like to thank Dr. Niranjan Bhatt from PATH and Dr. Imran Nisar from the Aga Khan University, Karachi, Pakistan. So this roadshow is now open for questions. and please use the Q&A button to ask your questions. If you want to ask your questions specific to either one or the other presenter, Dr. Nisar or Dr. Bhatt, please let me know. I already have a question from Mei Shang, who has two questions, Niranjan, that I will ask you, and then maybe Dr. Nisar can reflect as well. Is there any clinical experience to share on the proportion of kids tested RSV positive but only presented sepsis or apnea, so who are not captured by the current or the extended SARI case definition? And is there any experience to share on consistently applying sepsis and apnea case definition clinically across different sites? So basically, is the extended SARI case definition good enough to capture one of the most life-threatening diseases in babies?
No, that's a great question. In terms of the proportion that present with apnea or sepsis, I don't have those numbers off the top of my head, and I suspect maybe the clinical disease session of this webinar series may have more information about that. But I think that in those situations, it is true that it's possible that the extended case definition might not even capture some of these cases. And therefore, in some situations, you would want to think about whether RSV is circulating, whether it's current RSV season, and a child presents in sepsis or apnea. And that, in many cases, will then rely on clinical suspicion. That can be difficult, to apply systematically in a surveillance system. But I think that in some cases that especially during the RSV season, these kinds of presentations may be captured and properly tested. And by the way, while I'm speaking, I wanted to apologize. I see from some of the chats that there was some disconnect between the slides and my discussion, and I'm not sure exactly whether that was resolved, but thank you for letting me know.
Thank you. Dr. Nisar, do you have anything to add to the response to Dr.? Go ahead, please.
Yeah, I think I agree with what Niranjan has said. So case definition does remain an issue even in Pakistan. So one of the case definitions that, or the syndromic case definitions that we used showed, although increased sensitivity, especially in the young children, but at the cost of specificity. So there needs to be, some work done around developing more appropriate case definitions.
And I think it is also an issue with understanding the context. So in some contexts, low and middle income countries, that presentation may be different, or maybe in different proportions than in high income countries.
True that.
I wanted to add, in response to Dr. Shang, that this question is particularly relevant in neonates, probably beyond the first month of age. It's very unlikely that sepsis or apnea without
respiratory
the extended case definition applying, it's rare. But in the first month of life, this is an issue that people are currently studying to see how we can include that in the case definition, and to what extent that's actually really relevant for the broader picture. So while maybe a few folks here are thinking about remarks or questions, Niranjan, what hurdles do you see to follow your advice? I'm sure everybody understands that it is important to include RSV surveillance systems within the existing influenza surveillance systems, but there are still hurdles. Which one do you see, and how can we overcome them?
I think one of the biggest hurdles is awareness. Having the policymakers in countries really understand the true burden of RSV or the potential burden of RSV and the need to dedicate the resources to adapt the system, improve the system to include RSV. That takes additional resources, it takes time, and it takes political will. And so that I think is one of the largest hurdles. RSV is not a specific disease that is well recognized in the population. Most people understand colds, they understand pneumonia, but the finer points of which pathogen is causing it may not be clear. And so really engaging with the policymakers in a country can help address this and convince them that this is a good investment.
Thank you. Thank you. And I have one more follow-up question for you. We learned that there are two main mechanisms of RSV prevention: maternal vaccination and infant immunization with a monoclonal antibody. Basically, both systems seem to be effective. You also discussed genomic surveillance, not just detection of the virus, but also sequencing the virus. To what extent is sequencing the virus important when we would vaccinate pregnant women? Is it really important to understand the genome of the virus in different countries when there is no escape really relevant to the community?
Right. I think that that is particularly true for RSV compared to SARS-CoV-2 and influenza, which do rapidly evolve and evade the population immunity and the vaccine protection. And so, for influenza and SARS-CoV-2, it's very high priority to monitor genomics and follow that drift. It is true that for RSV, this is less important. In terms of the immunogens that are involved with RSV and the protection provided by those interventions, it's relatively stable. So it wouldn't be a high priority for countries to conduct genomic surveillance, but it is still, a remote possibility, and therefore contributing specimens to global surveillance efforts will still be important.
Thank you. Dr. Nisa, can you reflect on the relative importance of local, regional, and global surveillance data and decision-making for a new vaccine like RSV in Pakistan? This is a question by Daniel Fakin.
Right. So thank you very much for the question. So I think, we in Pakistan have been engaging with various stakeholders with regards to the, introduction of the maternal vaccine. So I think there's the most important concern that arises from everyone is that we have to show the burden of the disease or convince the policymakers and people and even the physician community for the burden of the disease, because as we discussed during the presentation as well, the testing is RSV testing is not widely available, and since you're not testing for it, you're not going to find it. And even in large tertiary care hospitals looking after sick neonates, RSV is not identified as a common as a cause of acute respiratory infections. So I think there needs to be systematic efforts to demonstrate sufficient burden at national level as well. We know from well-characterized research studies and longitudinal cohorts and even etiological studies that there is a substantial burden, but I think more national level data needs to be produced for policymakers and clinicians.
Thank you. Thank you. I think I have heard this before from people from other countries, that national data are important for decision makers. Evangeline Obodai asks, maybe Niranjan to you, whether you foresee challenges using two different case definitions, the traditional and the expanded case definition of SARI for RSV sentinel surveillance.
Yes, I mean, there is definitely potential for confusion when you have two different case definitions. And I think that the major distinction here is with the age groups. And so when you're looking at younger children, you would want to consider the extended SARI case definition. I think that concern for confusion was part of the reason why the pilot implementation of RSV was conducted among the influenza surveillance sites to, really look into, is this going to cause a problem? And I think what they were able to demonstrate was that with the appropriate resources and training, it is possible for the operators of the surveillance system to properly, distinguish between the two case definitions and apply them in the right context. I mean, it's not a perfect solution, but I think that they've shown that that's feasible and can be implemented worldwide.
Thank you. I agree. It seems to be that it is applicable, Dr. Obodai, even though there is room for confusion. So if there are no other questions, and I can see a lot of people are still here on the call in the meeting, I just wanted to check with both of you that what you would like us to take home. And one of the things that I take home is that even though it's a major effort to start a robust surveillance system, it's a very simple message. Use the existing sentinel surveillance system and you will get important data that will help to introduce RSV immunization. Is that a good message, or is there anything else that you would like us to go home with after this roadshow? Maybe first Niranjan, and the last words for Dr. Imran Isan.
So all I would say is that, as with Lewis, I was also trained as a pediatrician, and RSV was a major part of my my education in pediatrics, and it is a major disease that every pediatrician has to deal with, and the idea of reducing that burden through these new interventions really could be fantastic. And so, any way that we can improve the opportunities for countries to adopt these interventions through surveillance to understand the burden, as well as to then document the impact of these interventions, would be great.
Thank you. Dr. Nisa.
Yeah, I think that's the one key message I would also like people on this call, on this webinar, to take away, that it's a golden opportunity to use the existing surveillance system to leverage upon them to collect additional information on RSV burden, and which can then inform decision making at the national level, and also generate your pre-vaccine introduction data, and and impact evaluation as well. So I think, so that's one of the key messages I would like everyone to take away.
Thank you. Start now. That's what you're saying, and I really like that. So thank you all for being here. Please stay for giving us your evaluation. And not before I thank the speakers sincerely for being here and giving us their thoughts and their very careful advice and experience and knowledge. So thank you all for being here. Please fill out the questionnaire. Now to see you all in our last 7th webinar, March 5th. Thank you very much. Bye-bye. Stay healthy.
Thank you.
Thank you. Take care.